Assalamualaikum and good day to all my dear students. My name is Dr. Aini Hayati and welcome to Complete Denture module. So my lecture today will be an introduction to Complete Denture, and as a start, we will also cover the anatomy. So just a brief introduction to Complete Denture module in dental faculty UiTM. We will cover some lectures pertaining to Complete Denture, and then concurrently you'll be going through the simulation lab. For the practical part of it, these are all to prepare you for the clinical years later when you will have to construct your own Complete Dentures clinically on patients. So let's get started. These are the specific learning outcomes that we will cover in this lecture. So first, you have to understand what happened after tooth loss. Okay, so the sequelae of tooth loss to the patients. Okay, indications, contraindications of Complete Dentures. Okay, and you will have to know the process of Complete Denture fabrication in the clinic and in the laboratory. Next, you have to know the anatomy pertaining to Complete Dentures, and this anatomy will cover the supporting and limiting structures of fabricating Complete Dentures. So we will start with this complicated diagram, but what I would like to convey from this diagram is that this is our masticatory system. Okay, the teeth do not stand alone. There are relations and interactions within all these structures where you have the functions of the masticatory system relates to the morphology of the face, especially of the face height, and this does also relate to how the patient behaves, or specifically how the masticatory system behaves. Okay, if you think about patients with teeth or dentate patient, okay, where we have teeth in the dentulous state, the teeth are supported with a periodontal ligament as a mechanism of support. But in edentulous state, where the patients do not have teeth, these periodontal ligaments are lost together with the teeth. This will also affect how it behaves in the temporomandibular joint, and the loss of teeth will also have some effects to the overall appearance and overall behavior of the patient. So we will cover this in the next slide. Okay, this is a sequelae of tooth loss. The first sequelae that I want you to understand is the facial height. The facial height is always divided into three different segments. Okay, we have the upper face height, the middle face height, and the lower face height. For patients who have lost their teeth, okay, so we know that this area will be affected. Okay, if you look at this patient that I put the photo on, this is her before the treatment, before she received her new dentures. So what you see here is probably the old denture, and this is her after she received her new dentures. The old dentures that need to be remade are probably worn out. Okay, so it affects the lower face height, where you can see that this height here is less than the face height after she received new dentures that restore the height of the teeth and the face to the correct face height. Okay, that's the first. Once the patient lost their teeth, they will have some reduction in the residual ridge. Okay, that causes the reduction in the face height. The second sequelae of tooth loss is we will talk about centric relation. Okay, when a patient is dentate, especially when they still keep their posterior teeth, the position of their bite can always be registered. Okay, if you try it yourself now, try and bite with the posterior teeth, you always go back to the same position of biting. And at the same time, your temporomandibular joint or your condyle always goes back to the same position in the mandibular fossa here. When the patient lose their teeth, become edentulous, especially the posterior teeth, this positioning is very difficult. Okay, you don't know, the patient will not be able to bite in the same position, okay, or in the correct position. But what we should do is we should always get the patient to have the condyle at one repeatable position in the mandibular fossa. How do we do this? We will cover that. Okay, that will be covered actually in your occlusion lecture. But what I want you to take home from this slide is, for patients we are fabricating complete dentures on, you must always make sure that centric relation is the mantra. Okay, you always want to bring the patient back to the centric relation. So next, what happened when the patient lost their teeth? The temporomandibular joint change. Okay, TMJ degeneration might start before edentulousness. So once they become edentulous, where they cannot have a stable bite, the degeneration might even become worse. Okay, and when the patient's been using dentures of poor quality, okay, the degeneration might also become worse and worse. So this is the reason why we as dentists should have the knowledge of complete denture for the sake of our patient. So we will always be able to prevent these problems from happening. Okay. Okay, the next changes, which I could say could be the most obvious changes to us as dentists, is the cosmetic change that happens extraorally. Okay, these are the things that we observe from the patient's appearance. First, deepening of the nasolabial growth. So where's the nasolabial growth? Okay, just follow my arrow here. This is the nasolabial growth viewed from this profile view. Okay, from the front, this is the nasolabial growth. Okay, I think it is obvious to us that as a person gets older, this groove will become more obvious, more accentuated. Okay, why does this happen? Of course, there's reduced laxity in the skin structure, but also once the patient actually lost their teeth, okay, this whole skin, also the whole structure of the skin here in the lower face height is not supported, okay, because the structures in here have been lost. Okay, so as the face falls or collapse, these grooves will also become more accentuated, become more obvious. Next is the decrease in horizontal labial angle. Okay, this refers to this angle of the lips when the patient is viewed from the front. If you compare these two photos, where in this photo here, obviously the patient has dentures in, okay, this lip line is almost parallel to the floor as compared to this lip line. Okay, so this is what we describe as the decrease in the horizontal labial angle. Third one is the narrowing of lips. I hope this picture is obvious enough to you that the upper lips, okay, you almost cannot see the upper lip of this patient when she doesn't have her dentures in. As compared to this photo, the lip fullness is there. Okay, so you can see the lips. The next cosmetic change that you can see in a patient with edentulous state is the increase in the columella filtral angle. Okay, what is columella? Columella is this structure here beneath the nose, and the filtrum is this structure here. Is the depressed structure on top of your lip. Okay, just beneath your nose. This is the angle we're talking about. So, when the patient is edentulous or the patients don't have anterior teeth, you will find that this angle will become more obtuse. Okay, it will become more than 90 degrees. Okay, in this patient of Caucasian origin, the angle is always restored back to 90 degrees. But however, I would like to remind you that we are working in Malaysia, where our patients are not Caucasian, and there are some differences in the facial structure of Asian patients as compared to the patients that you see in textbook, where they always describe the Caucasian patients. In Caucasians, of course, this is 90 degrees, but in Asians, our normal angle for this columella filtral angle is always acute. Okay, so in Asian patients, if after you provide the dentures, the patients go back to this angle of 90 degrees columella filtral angle, you probably have not restored back to the fullness, to the correct fullness of the lips. Next is the prognathic appearance. If you compare these two photos of the same patient, okay, the chin looks prognathic. Okay, it looks like it's jutting forward because of the loss in the supporting structures behind this structure. Okay, because it is not supported. Okay, no teeth. Maybe the ridges have been very resorbed, so the lips here are not supported. So the lips collapse, leaving behind the chin structure, the mandibular bone here, and the patient will look prognathic. So what are the indications and contraindications for complete denture treatment? The question here is, should you just make a denture? Okay, so indications for treatment is, of course, when the patient is edentulous, when the patient comes to you without any teeth. Of course, the first thing that comes across your mind is you want to provide the patient with dentures. Sometimes the patient is not totally edentulous. Okay, maybe the patient is still partially dentate, and they come to you, but they have very few remaining teeth. Some are very mobile, some are periodontally affected, some have very hopeless prognosis that you know that you cannot save the teeth anymore. So maybe this patient is also a candidate for complete denture. Okay. And when the patient comes to you with current dentures that are heavily worn, that she has been using for a very long time, and you cannot do anything to modify the denture anymore, so these are the patients that you want to provide a new complete denture for. Contraindications. To whom you should not provide complete dentures. Okay. First thing first, as with any dental treatment, especially for prosthodontic dental treatment, you always want to be careful for the patients who have extreme expectation. If they, in the first visit, they already mentioned to you that they want something that looks like a Hollywood smile, or something that will be similar to their natural teeth, you have to be careful and try to probe for more. Maybe the patient has something that you cannot provide for. So be careful with this patient. You don't want to promise the moon and the stars. Okay? You know that you are human and you are providing a prosthesis, so some things are limited. Okay? So be careful with this kind of patient. Maybe some patients you can talk through with. Okay? and let them know that some things might not be possible, that false teeth are not going to be as good as your natural teeth that you have lost. Okay, something that's been given to you from God. Some patients can accept this and you can proceed, but you should be able to detect these patients with extreme expectation. Okay, I hope that's clear enough to you. Maybe patients who are terminally ill. Sometimes these patients you will see when you go to your hospital attachment. Okay, they will come to you with cancer or with terminal stage cancer, and they tell you that they have difficulty eating because they don't have teeth. Okay, but you have to think again. Do you really want the patient to go through all the hassle of making dentures? And maybe the patients will not be able to use the denture properly because of maybe mucositis that they have in the mouth. Okay, because they're already on the cancer treatment, and maybe the patients have a few weeks left. Okay, so these are the patients that you want to advise accordingly. Okay, maybe denture is not for them. And look for patients with mental health. Okay, sometimes having said that, I'm not saying that all patients with mental health cannot be under our treatment. Okay, but you have to look for patients who cannot give cooperation. Okay, number 4 is when the patient is not interested. Okay, this is also a contraindication. Okay, maybe some patients were brought to the clinic by their family members, and maybe their daughters or their son insist that this patient receive their complete denture. But you know that the patient is happy with whatever that they have now, and they don't want a new complete dentures. Okay, these patients might not be cooperative to you. Okay, because they don't want it. They don't want to be in the process. And some anatomical factors. Okay, like very extreme ridge resorption, in which you know when you provide the dentures, it will just be floating on the floor of the mouth. Okay, and maybe extra large torus. But this you will have to evaluate whether the torus can be surgically removed. Okay, after which you can continue with your fabrication of complete denture. Okay, but otherwise, look for any anatomical factors that might make complete denture fabrication difficult, and you might want to refer this to the nearest specialist, the nearest prosthodontist. So what are the limitations of complete dentures? Of course, anything that you do as a human always have limitations. Comparing complete dentures to implant over denture, of course, complete dentures have less stability than the implant over denture. In terms of retention, it is not as good. Perceived chewing efficiency is less, and the chewing efficiency of complete dentures is not as good as you can compare it to implant over denture or to the patient's natural dentition. Now we will go through the step-by-step of complete denture fabrication. The column on the left, the yellow column, is the steps of fabricating complete dentures in the clinic, so the clinical steps. And on the right is what you have in the laboratory steps. So after a few steps that you've done in the clinic, you will have to bring it to the laboratory, and the process continues, okay, until the denture delivery stage. For complete denture fabrication, you always start with the prosthodontic examination and diagnosis. And usually in the same visit, we'll get you to do the primary impression. Okay, after that you dismiss the patient. You bring the impression to the lab and pour the impression. So for the next visit, you already have the cast for the treatment planning and the denture design stage. So you have to present the case together with the cast that you already have in hand. After the case is approved by your lecturer or your supervisor, you dismiss the patient, and then you bring the cast for fabrication of special trays. Once you have the special tray, you can bring the patient in again and take the secondary impression. Okay, and then you will bring the secondary impression to the lab, pour it so that you have your master cast. Okay, from the master cast then only you fabricate the wax rim, which you use for your maxillomandibular registration. Okay, once you've registered your MMR, you mount the cast on the articulator and you set the teeth on the articulator. So this is the stage where you already have your trial dentures. So you bring your trial dentures to the clinic and do the try-in the patient's mouth. If everything is okay, you can bring the trial dentures back to the lab and process into final acrylic dentures. And the last visit will be the denture delivery. I missed another step here. After the delivery, 1 week after the delivery, you always bring the patient back in for a review visit. Now we've come into the next phase of this lecture, where we discuss the anatomical structures for complete denture. Why anatomy is very important in complete denture? I will tell you that every time you go to your clinic, for every clinical step of complete denture, it is always pertaining to the anatomical structures. And you always have to have your anatomy knowledge planted, okay, etched in your brain. The knowledge has to be there at the back of your mind all the time. The success of your complete dentures, I would say it depends on your knowledge on the anatomy. Okay, the anatomy relates to the design of the dentures. Okay, so the anatomy has to be respected so that you provide dentures with support, with retention, and the dentures with stability. Okay. The concept is the more tissue area that the denture covers, the more support is gained for the denture. I want you to bring this knowledge throughout your career, that for complete dentures and any dentures for that matter, the anatomical structures have to be respected. You want more tissue coverage for the best support for the denture. So that's why maximal denture extension up to the limiting structures have to be provided. Okay, just think about this. That especially for complete dentures, you want to extend the base of the denture as much as possible. Okay, but you cannot go up to the throat because why? It has some limiting structure. Okay, now let's go through the anatomy of the maxillary stress-bearing area. This is the intraoral photo of an edentulous ridge of a maxilla. What I want you to do is, I want you to really go through all the anatomical structures and the anatomical landmarks from your textbook. Okay, but the maxillary stress-bearing area that I want to stress in this lecture are 3 structures. Okay, so it is divided into the primary areas and the secondary areas. This for maxillary stress-bearing area, first is the hard palate. The whole hard palate should actually be covered by the denture base. So this is the main area that receives the load from your complete denture. Secondly is your tuberosity. Okay, this is your tuberosity. These areas are the areas which should be covered by the denture base. And the reason why these areas are termed as primary bearing areas is because the bone underneath this mucosa do not undergo resorption. Next is the secondary area. Secondary stress-bearing area for the maxilla is the alveolar ridge. The hard palate. The mucosa of the hard palate is classified as the masticatory mucosa with keratinized layer. What does this tell you? That the overlying mucosa in this hard palate area, it can change in thickness, and it is normally very tightly bound to the underlying periosteum. This is the reason why this area accepts the load from the denture very well. The next primary stress-bearing area for the maxilla is the tuberosity, as I mentioned previously. In these photos here, I'm showing you the different situations of how tuberosity can present to you clinically. On this upper photo on the right-hand side, the tuberosity can actually hang down very low. In this situation here, the patient used to have teeth in this area, which has been retained for so long, and the teeth has over-erupted, and it brings down the tuberosity with it. In this situation, usually you have to do some modification before you actually provide the patient with maxillary complete denture. So for the alveolar ridge, resorption can occur throughout life following extraction, and it can be rapid in the first few months. The crest of the ridge is the important area for support. Hence, you have to check for any irregularity, if there's any sharp bony spicules, and the mucosal architecture. You have to make sure that you palpate the mucosa all around. As the bone resorbs over time, its potential for support is not good enough, not as good as the hard palate. So this is the reason why the alveolar ridge is considered secondary to the palatal bearing area. Okay, when I mentioned that the denture base has to be extended as much as possible, okay, if you follow my arrow here, it has to cover all areas that has been mentioned as the stress-bearing area, which is the alveolar ridge, the palate, and the tuberosity. And the extension is always distal to the tuberosity into the hamular notch on both sides. However, how do you know where to end the flanges of your complete denture? This is when we discuss the limiting structures that limits the extension of your flanges or the base of your complete denture. So the limiting structures for the maxilla should be the movable tissue, the sulcus. Okay, so the sulcus is also considered movable tissue. This structure is identified when you do your border molding. You have to identify the limit of the sulcus, where the flange should stop during the border molding process. You should never extend the flange of the denture beyond the sulcus. As the sulcus moves during function, it has the potential to push the flange and cause the denture to be dislodged. So the three areas of the maxillary limiting structures. First is the labial vestibule, shown here in yellow line. Next is the bilateral buccal vestibule, okay, where you have my green lines here. And of course, posteriorly, where should you limit is the posterior palatal seal area or the vibrating line. Okay, now we have to go through the mandibular anatomical landmarks. On the left is the intraoral photo of your mandibular ridge. As someone who is not familiar with intraoral examination, I can imagine that this can be actually quite confusing for you. But what I want you to do is to compare this with a graphical photo of your mandibular bone. This is your mandible. This is your condyle. This is the angle of the mandible. And this is where you have your retromolar pad. So if I superimpose this mandibular bone onto your intraoral clinical photo, your condyle is way up here, and if you trace the mandible anteriorly, you will find that there is the retromolar pad, and this is the buccal shaft area. Okay, so the buccal shaft is always next to the retromolar pad. Okay, these are the anatomical landmarks that I mentioned here are the important landmarks that I want you to remember. So I'm not going to say everything on the photo, but we're going to go through the most important anatomical landmarks for the mandibular residual ridge. This is the premylohyoid eminence. It's not easy for you to identify this structure of premylohyoid eminence intraorally. However, what you can do is you have to palpate, and in doing so, you should be able to find an area of a bony eminence. So for the mandibular stress-bearing areas, of course, we have the primary area and the secondary area. So what do you think is the most important mandibular stress-bearing area for the mandible? It is the buccal shelf. Okay, this is the area that does not undergo bony resorption, and it literally stays the same throughout the patient's life. The buccal shaft is the area medially bound by the crest of the ridge and laterally by the external oblique ridge. And the secondary area for the mandible is the alveolar ridge. The buccal shaft, it is the most stable area in the mandible, and it is not affected by bony resorption. If you look closely and if you palpate this area, it is actually at the right angle to the vertical occlusal force. So the limiting structures for the mandible, which you should remember, for the buccal and the labial borders. First, of course, you have the labial vestibule. So the labial vestibule is where you get your mentalis muscle attachment. This is the reason why it is a movable structure as the muscle relax and contract. So it is where you should not extend your denture, your mandibular denture flange. Next is the buccal vestibule, where you have your buccal frenum. For the distal borders of your denture, of course, you have your ramus up here, and the ramus is here just distal to the retromolar pad. So the landmark that you have to always remember for the mandibular residual ridge is, of course, the retromolar pad. So this is your retromolar pad. In some patients, it is very easy to identify the retromolar pad, that structure distally that is rounded and spongy. For the distal buccal borders is where you have the attachment of your buccinator muscle. This is your buccinator muscle from the cheek. Okay. And this is the external oblique line, which should be where your denture flange terminates. So lingually, how do you know where to extend the lingual flange of your mandibular complete denture? So I put the photo of your mandibular bone looking from the inside. Posteriorly, your lingual mandibular flange should be limited by the mylohyoid muscle, which actually forms the floor of the mouth. So if you can imagine, this is where you have the tongue and you always have your mylohyoid muscle. That becomes the floor of the mouth. In no situation should your denture extend beyond this area, which actually will be interrupted by the mylohyoid muscles action. Posteriorly, the retromylohyoid fossa does not have any muscle action in this area. It is therefore recommended that the flange should be extended to the mylohyoid fossa in ensuring maximal coverage and maximal extension without interfering with any muscular action. That is all for this lecture. Thank you.